Good morning, ladies and gentlemen. The topic of today's lecture is dermatosis of the neonate. Since this is a big chapter, I'm going to split my lectures into two. So today I'm going to discuss the non-infectious causes of pustular lesions in the neonate. Then I'm going to discuss the disorders which develop in neonate because of the maternal transfer of autoantibodies. And the third part of this lecture will be the neonatal cold injury and the disorders which are associated with hypothermia. So let's proceed with the lecture. Before I talk about any specific disease, let's first go through this table. This table shows the differential diagnosis of neonatal pustular eruptions. So you can see that the neonatal pustular eruptions are divided into two major categories: the infectious causes and the non-infectious causes. The infectious causes I will be discussing in the next lecture from the same chapter. And the infectious causes include the congenital or neonatal candidiosis, congenital syphilis, herpes simplex, impetigo, malassezia pustulosa, neonatal listeriosis, scabies, and neonatal acne. The non-infectious causes of neonatal pustular lesions I am going to take up in today's lecture. And these causes include miliaria, eosinophilic pustulosis, infantile acropustulosis, Langerhans cell histiocytosis, neonatal pustulosis of transient myeloproliferative disorder, pustular psoriasis, toxic erythema of newborn, and transient pustular melanosis. Toxic erythema of newborn. The toxic erythema of newborn is a common, transient, blotchy, red macular rash, sometimes with small pustules, seen in first few days of life. It develops in 30 to 50% of children. A high prevalence of this dermatosis is found in higher birth weight newborns. It occurs more frequently during the summer months. It usually appears in first 24 to 48 hours of life with equal sex prevalence and occur in all racial groups. So first thing about the toxic erythema of newborn is that it's a very common condition. 30 to 50% of children are involved. And the children are usually of higher birth weight, and the disorder is frequently seen in summer as transient red macular rash, sometimes with pustules, with no particular racial predominance or sex predominance. Pathophysiology. There is frequently an associated blood eosinophilia. The intrafollicular location of mature pustules has led to the suggestion that the inflammatory response is elicited by some component of the sebum. So the lesions are intrafollicular. Scanning electron microscopy of neonatal skin show that the colonization of the hair follicle epithelium by Staphylococcus is common in early life, which can be a predisposing factor. The pustular lesion is characterized by eosinophil infiltration of the outer root sheath of one or more hair follicles. The pustular lesions show intrafollicular accumulation of eosinophils immediately below the stratum corneum. Causative organisms. No pathogenic bacteria are isolated from the pustules. No environmental factor have been demonstrated. Clinical features. In most cases, the onset of toxic erythema of newborn is within 48 hours after birth, but it may occur at any time until about the 4th day. So it very rarely present at birth. So it neither present at birth nor it present after 1 week. So the time of onset of this condition is from 2 days to 4 days after birth. Eruption initially takes the form of a blotchy, macular redness, most profuse over the trunk, but also appear on the face, proximal limbs, especially thigh, and sparing palm and soles. So they also note down the characteristic distribution, the trunk, face, upper arm, upper limb, and sparing palm and soles. Most severe cases, the urticarial papules arise within this blotchy area, and these papules are seen in 10% of the cases, and sometimes these are surmounted by tiny pustules. Now it can be confused with Miliaria crystallina. I will subsequently tell you about the significant feature of Miliaria crystallina. In mildest cases, the macule fade within a day. If not in a day, then in few days. It has to be differential diagnosis. It has to be distinguished from several other disorders that feature the pustular lesions during the neonatal period, particularly miliaria, as I've already mentioned, transient neonatal pustular melanosis, incontinentia pigmenti, herpes simplex, varicella zoster, impetigo neonatorum, and malassezia furfur pustulosis. Complications. The disease is a benign condition. The infant appears well, unperturbed by the eruption, and there is no complication. There is spontaneous recovery, which occurs rapidly within 3 days, but recurrence are occasionally seen. Investigations are rarely needed, but in case of doubt, microscopic examination of a smear of pustule content will show eosinophilia and negative bacterial or viral culture. So since it's a self-limiting condition, either no treatment is given, or if you want to give something, then a bland emollient will be sufficient. Now the miliaria. I have already discussed miliaria in the relevant chapter, but now today I am going to discuss this condition in a neonate. Miliaria crystallina is a self-limiting eccrine gland disorder due to blockade of sweat glands, resulting in rapidly evolving non-inflammatory vesicles that easily break down. So miliaria is usually divided into 3 subtypes. The most superficial is Miliaria crystallina, which involves the blockade of the eccrine duct at the stratum corneum. Then is the Miliaria rubra, when the blockade is in the mid-epidermis, and Miliaria profunda, where the blockade is at the level of dermo-epidermal junction. Miliaria occur in 3 to 8% of neonates, and Miliaria crystallina is the commonest form of Miliaria in the neonates. And of course, all miliaria are common in summer months. So this condition is also common, and I've already mentioned the toxic erythema of newborn is also common in summer months. Miliaria has equal sex prevalence and no racial predominance. Pathophysiology. The immature sweat ducts, high level of heat and humidity are important predisposing factor. In addition, occlusive clothing, hypernatremia, or hyperaldosteronism are other predisposing factors. So Miliaria crystallina is characterized by presence of intracorneal or subcorneal vesicles in communication with the sweat ducts. Sometimes it is infected by Staph epidermidis or Staph aureus, and the environmental predisposing factor, as already mentioned, are heat, humidity, occlusive clothing, and plastic sheets wrapped around the baby. Clinical features. Miliaria crystallina presents as crops of clear, thin-walled, superficial vesicles, 1 to 2 millimeter in diameter, without associated redness, resembling drops of water on the skin. They are exceedingly delicate, generally rupture within 24 hours, followed by bran-like desquamation. Lesions are symptomatic, arise most frequently during first 2 weeks of life, and particularly likely to be seen on forehead, scalp, neck, and upper trunk. So, among the clinical features, Miliaria crystallina is different or distinct from toxic erythema of newborn. Number one, in having multiple delicate small vesicles without surrounding erythema. And I've already mentioned the toxic erythema of newborn starts as the blotchy erythema. So erythema is absent in Miliaria crystallina. Secondly, toxic erythema of newborn develops at 2 days to 4 days of birth, while Miliaria crystallina develop anywhere after 2 weeks. And as far as the distribution is concerned, the distribution is typically similar in both cases, that is the trunk, face, and upper limbs. The Miliaria rubra, which is a deeper form of Miliaria, comprises of red papules and papulovesicles, 1 to 4 mm in diameter, on background of macular redness. Sometimes wheel-like lesions occur. So now the lesions are bigger, and there are papules with papulopustules. Frequently, some lesions are pustular, but this does not necessarily indicate a secondary infection. So, staphylococcal secondary infection is common in Miliaria rubra, which is known as the periporitis. So, Miliaria rubra probably occur most frequently during a neonatal period. These lesions are symmetrical, most often in flexural area, especially around the neck, groin, and axilla, where the baby sweats more. Lesions are itchy or sore, so these lesions are symptomatic, and child is restless and distressed. The lesions keep on occurring in crops. Each crop subsides in 2 to 3 days, but recurrences are common unless the provocative environmental conditions are modified. The recurrent bouts of Miliaria pustulosa are common findings. Miliaria profunda is very uncommon in neonate, and it usually occurs in adults where there have been repeated episodes of Miliaria rubra. Differential diagnosis. Miliaria crystallina is distinguished from viral infections, for example, herpes simplex, when it occurs during the first few days of life. Miliaria rubra is often confused with toxic erythema, especially if it becomes pustular. And Miliaria pustulosa may also be confused with infantile acne or folliculitis. Complication is staphylococcal infection, abscess formation. Miliaria crystallina spontaneously improves as the sweat ducts mature. But Miliaria rubra needs treatment, especially when the predisposing etiological factors like high heat and humidity and occlusive clothing is removed. Management. Miliaria crystallina is spontaneously improved without therapy over a few weeks. The first line treatment of Miliaria rubra is to remove the predisposing factors, and the second line treatment is antibiotics, topical or oral when secondary bacterial infection is present. Sometimes you also need mentholated creams or lotions like lotion calamine, or in severe cases, mild topical corticosteroids. The third condition I'm going to discuss is a special condition which is known as the transient pustular melanosis. So all these three words are important to describe the clinical features of this condition. It's an early onset variant of toxic erythema of newborn. Lesions are usually present at birth. The most characteristic component is 1 to 3 millimeter flaccid, superficial, fragile pustules with no surrounding redness. So, since the occurrence is at the time of birth, this differentiates this condition from toxic erythema. And secondly, it is not associated with surrounding erythema, which is similar to Miliaria crystallina but different from toxic erythema of newborn. Etiology is unknown but commoner but not confined to the black or colored skin neonates. These pustules occur at any side but favor the chin, neck, forehead, back, and buttocks. Sites where these pustules rupture are marked by a small collarette of scale and which may be surmounted by a pigmented macule. Pigmentation may persist for about 3 months. Skin biopsy of the pustules show intra or subcorneal collection of neutrophils and few eosinophils. The pigmented macules demonstrate basal and suprabasal increase in pigmentation only, apparently without pigmentary incontinence, and bacterial cultures are negative. So the condition is different from the previous two conditions in that there is an increased tendency to develop macules, pigmented macules after the pustules. That's why the condition is more common in black or type 4 or 5 skin neonates. So as far as the biopsy of pustule is concerned, it shows intra or subcorneal collection of neutrophils and few eosinophils, while the pigmented portion is because of the basal and suprabasal increased pigmentation. There is no interface change here. Infantile acropustulosis is an uncommon disorder of unknown etiology. It is suggested that the eosinophilic pustular folliculitis and infantile acropustulosis may be the different manifestations of the same disease. It is also suggested that at least in some cases, infantile acropustulosis occur following a successful treatment of scabies. So this you must have encountered in your clinical practice, that many of the patients, young neonates suffering from scabies, present with multiple pustular lesions on palm and soles. Individual lesions appear as tiny red papules that evolve into vesicle and pustules in 24 hours. These vesicular pustules present with in recurrent crops of intensely itchy 1 to 4 mm lesions principally on the sole and side of feet, on palms, dorsa of feet, hand, and fingers as well. Each crop lasts for 7 to 14 days and recur at the interval of 2 to 4 weeks. More numerous and more frequent in summer months. Excoriation or itching results in erosions and then crusting. Healing is succeeded by macular post-inflammatory hyperpigmentation. In majority of cases, onset is in first year of life, particularly during the first 6 months. So this is not a condition of newborn. Differential diagnosis is usually clinical. Predilection to palm and soles and recurrent attacks differentiate this disorder from other pustular eruptions like toxic erythema, miliaria, and transient pustular melanosis. Scabies is a diagnosis which is most frequently confused and difficult to exclude, where there is doubt a therapeutic trial of anti-scabies treatment is justified. Investigation. Histopathology show a well-circumscribed subcorneal or intraepidermal pustules comprising of neutrophils, and dermis shows the perivascular lymphohistiocytic infiltrate. DIF and indirect immunofluorescence studies are negative. Management is with potent topical corticosteroids with or without occlusion, dapsone in a few cases, and topical calcitol. The attack occur with gradually diminishing number of lesions with decreasing frequency until these cease altogether. But it may take few months or even 2 years. So the last condition in this category is the congenital erosive and vesicular dermatosis healing with reticulate supple scarring. So the first part is a normal occurrence, erosive and vesicular dermatosis, but the second part is typical of the condition, that is, it heals with a reticulate supple scarring. So this condition present in neonates as erosive, ulcerations, vesicles, red skin affecting 75% of the skin surface, and this heal with a distinctive reticulate scarring. A rare self-limiting blistering disorder of unknown etiology occurs at birth, and majority of affected infants are premature. And occurrence is greater in boys as compared to girls. You can see this reticulate scarring on the trunk, on the arms, and on the hands. Biopsy of vesicular lesions shows spongiosis, epidermal necrosis, superficial and deep dermal inflammatory infiltrate, mostly neutrophils. DIF does not show any specific pattern of deposition of immunoglobulin C3 or fibrin. The DD is from the infective blisters like herpes, then also epidermolysis bullosa, which causes scarring, the bullous ichthyosiform erythroderma, incontinentia pigmenti, aplasia cutis congenita, focal dermal hypoplasia, and staphylococcal scalded skin syndrome. Spontaneous healing occur in 2 weeks to 3 months. Baby need to be nursed in appropriate neonatal unit for management of fluid balance, temperature control, and infection. Non-adhesive dressings like silicone dressing is needed for first few weeks till the healing occur. This can prevent the scarring. There is no specific treatment of scarring if they develop. Now, this is the second part of my today's lecture, and this is the disorders that are caused by transplacental transfer of maternal autoantibodies. In this section, I'm going to discuss a few diseases. The first is the neonatal pemphigus vulgaris. Several cases of transplacentally transmitted pemphigus vulgaris have been reported in neonates. Not all mothers have clinically apparent disease during pregnancy, and in other, the disease is mild. So it is possible to have neonatal pemphigus vulgaris when the mother, although is a patient of pemphigus vulgaris, but is not suffering from active disease at the time of birth. Affected infants have cutaneous and mucosal erosions or bullae, and several have been stillborn. Approximately one-third of the neonates born to mothers with pemphigus vulgaris are unaffected by the disease. So, two-thirds of the babies are affected. This is a clinical presentation of pemphigus vulgaris in a neonate. DIF is positive in all skin biopsy from the affected infants. Circulating IgG pemphigus autoantibodies is also detected in majority. There are no cases of infant born to mothers with pemphigus requiring treatment. Lesions resolved spontaneously in 3 weeks, and known lesions have occurred after birth because these antibodies are transferred from the mother. So within a few days, these antibodies are lost and the disease resolves. Circulating IgG antibodies become undetectable by the end of second month. The transplacental transmission of pemphigus foliaceus have similarly been described. The second condition to be discussed is the transplacental pemphigoid gestations. Cutaneous lesions occur in about 10% of infants born to mothers with pemphigoid gestationis, although maternal IgG anti-basement membrane autoantibodies can be found in all infants of the affected mothers. The lesions may be present at birth or may appear any time up to the third day of life. Lesions vary from evanescent, non-specific, red or urticarial papules to fully developed bullae that can be extensive. You can see these plaques, then crusted lesions, few tense blisters, and DIF showing C3 deposition at the basement membrane. A spontaneous regression of lesion occur in 3 weeks, just like neonatal pemphigus vulgaris. DIF is normal after the first month. Risk of fetal and infant morbidity and mortality in mothers with pemphigoid gestationis is debated, but there appears to be an increased risk of premature delivery. The risk of adrenal insufficiency should be considered in neonates whose mothers have required or are using high dose of oral prednisolone. This can cause severity of condition in newborn. Then the third condition to be discussed is neonatal lupus erythematosus. It's a rare syndrome comprising of mainly two things: a transient skin lesions which resembles the subacute cutaneous LE and a heart condition which is the congenital heart block. Neonatal LE occur in babies born to the mothers with clinical or subclinical autoimmune connective tissue disease, which may not always be SLE. It is associated with the transplacental passage of maternal autoantibodies to RNP, to the SSA, ROSSA, or LASSB, and rarely U1 RNP. Only 1 to 2% of RO positive or LA positive mothers will have babies with neonatal LE. But babies from subsequent pregnancies have 20 to 25% risk of skin and cardiac disease. So the incidence of having neonatal LE in RO or La positive mother is just 1 to 2%. But after the birth of a baby with neonatal LE, there is 20 to 25% increased chance of having the disease in subsequent pregnancies. Associate disease. I have already mentioned the risk of connective tissue diseases later in life is increased in these babies. pathophysiology, is now accepted that the disease is provoked in fetus or newborn infant by maternal IgG autoantibodies that have crossed the placenta. The anti-La, anti-native DNA, anti-cardiolipin, anti-nuclear antibodies or rheumatic factor is present in addition to Rho antibodies. Up to 60% of the mothers of infant with neonatal LE have no clinical evidence of connective tissue disease at the time of birth, but they may develop these diseases later on. There is substantial risk of subsequent development of symptoms of autoimmune disease. Up to 40% of mothers have systemic LE, subacute cutaneous LE, or Zika syndrome. Most recently, it is recognized that 5% of women of childbearing age who present with leukocytoclastic vasculitis at the time of birth will have 5% of babies with neonatal LE. So, leukocytoclastic vasculitis developing in a pregnant lady can predispose 5% of their babies on having the neonatal LE. Pathology. A skin biopsy specimen from infant with cutaneous lesions demonstrate the feature of LE, which is the epidermal atrophy, liquefactive degeneration of the basal keratinocytes, colloid bodies formation, and perivascular and periappendigeal lymphohistiocytic infiltrate. DIF is positive in 50% of cases. The most important environmental factor is the sunlight. Clinical features. The most infants with neonatal LE have either a skin lesions 90% or cardiac lesion or only cardiac lesion in 1%, and in 8% both these two features are present. In about 2 to 3% of the cutaneous lesions are already present at birth, but 1/3 of the patients, the lesions develop in first 2 to 3 months. Skin lesions are well-defined annular macules or plaques, predominantly on the face, particularly on the forehead, temples, upper cheek, and neck. A characteristic spectacle-like distribution of lesions around the eye, the raccoon eyes, is common. Provocation or exacerbation by sunlight is reported. Follicular plugging is not common, but scaling is common. Degree of atrophy and telangiectasias are frequent long-term sequelae. There can be permanent hair loss. Most cases, skin lesions resolve within the first year, but areas of atrophy telangiectasias may remain prominent. Differential diagnosis. The atrophy and telangiectasia of cheek is seen with photosensitivity disorders like Bloom syndromes, Rothman-Thompson syndrome. In these disorders, skin lesions are not present at birth and generally appear later than in neonatal LE. Complications and comorbidity. Systemic features are detectable in over half of all infants with cardiac involvement, which is the commonest. Congenital heart block due to fibrosis of the conducting tissue occurs in 1 to 2% of RO positive pregnancies. The Rho antibodies bind to cardiac conduction cells, leading to altered membrane repolarization and selective damage to atrioventricular node. This congenital heart block is detected by 18th week of gestation by ultrasound or electrocardiography. So it can be detected intrauterine. So this is an image of complete heart block. You can see that the P waves and the QRS intervals are totally dissociated from each other. So both of them, they are producing independent impulses. The block is generally permanent, not associated with cardiac abnormality like septal defect, and half of the infant require pacemakers. A smaller proportion of infants have a combination of hepatomegaly, splenomegaly, lymphadenopathy, and pneumonitis, which are all mild in degree and transient. Autoimmune hemolytic anemia and thrombocytopenia is also seen as in a small proportion of cases. CNS involvement is also seen, characterized by asymptomatic vasculopathy or more serious cerebral vasculitis. Disease course and prognosis. Infants with skin lesions alone or with skin lesions and systemic features other than heart block generally show little sign of residual disease by the end of 1 year. So if only skin condition is present, the children is almost okay after 1 year with a hint of erythema and telangiectasias. But conduction defect in heart is permanent and severe and has a significant mortality. Risk of recurrence and further pregnancy increase to 20 to 25%. Spontaneous abortion or stillbirth do not appear to be more frequent. Neonatal early autoantibodies disappear from infant serum within about 6 months. Investigations. Skin biopsy, as mentioned, will show the full signs of SLE. And if combined with the DIF, then DIF is also positive. Management. As far as the skin lesions are concerned, no specific management is required except mild topical corticosteroids and sun protection. Occasionally, thrombocytopenia, hemolytic anemia, hepatitis warrant systemic steroid therapy. And in 50% of infants with heart block requires permanent pacemakers. The pregnancy of women who have Rho, La, or U1RNP antibodies should be monitored to detect the low fetal heart rate. Treatment with high dose of systemic steroids may be indicated for fetal bradycardia, and this treatment may help in treating this heart block, which is going to develop in those infants, in those fetus in which there is bradycardia. Now I have come to the last or third section of my today's talk, and that is the disorders of subcutaneous fat. And we are going to discuss 4 conditions here: the cold paniculitis, neonatal cold injury, subcutaneous fat necrosis of newborn, and scleroderma neonatorum. Cold paniculitis. It is provoked by cold exposure to infants which appear to be predisposed. So it is often seen on cheek, on exposure to extremely cold air, exposure to ice bags applied as a therapy of supraventricular tachycardia, or the frozen lollies. Characterized by indurated, warm, red subcutaneous plaques and nodules that appear within hours or days of appropriate cold exposure. If biopsy is done, it will detect lipocyte rupture, leading to cystic cavities surrounded by lymphohistocytic infiltrate and few neutrophils and eosinophils. The induration resolves in a week or so, leading some degree of PIH. No treatment is particularly required. The neonatal cold injury. Cold exposure of small for date neonates causes hypothermia associated with lethargy and generalized pitting edema of the skin. Other factors that have predisposing role include intrauterine growth retardation, which results in relatively thin panniculus, and tight wrappings which restricts the muscular activity. The infants are usually full-term, born at home, but small for date. Great majority of cases present within first 4 days of life and usually during the first 24 hours. And it's important to mention here that all these babies are born in cold weather. The most striking feature is intense redness or cyanosis of face and extremities with firm pitting edema beginning at the extremities and spreading centrally, becoming progressively more indurated. Skin feels cold and baby is usually hypothermic with low core temperature. Associated non-cutaneous features include immobility, drowsiness, poor feeding, vomiting, oliguria, gastrointestinal bleeding with vomiting of altered blood and or melena. The condition is less common in developed countries because of the improved heating at homes, reduced frequency of home deliveries, and abundant and the abandonment of the previous habit of bathing the babies immediately after the birth. Subcutaneous fat necrosis of newborn. It's a rare, transient form of panniculitis, mostly affecting the full-term infants, usually in first few weeks of life. Generally occur in full-term or post-term infant, normal birth weight in first 6 weeks of life. There is equal sex incidence. It is associated with maternal preeclampsia, diabetes, perinatal asphyxia, and hypothermia, including therapeutic whole blood cooling. Pathophysiology. The precise cause is unestablished, but variety of insults that include the birth asphyxia, maternal preeclampsia, diabetes, obstetric trauma, hypothermia, and hypothermic cardiac surgery. Most important predisposing factor appear to be a combination of local tissue hypoxia and cold injury. This might explain the predominant location of this condition on shoulder and buttocks. Histologically, there is intense lobular panniculitis. You can see dense inflammatory infiltrate in the lobules of subcutaneous fat, sparing the septa. Adipocytes are swollen. You can see the adipose swollen with characteristic radial eosinophilic crystals. Dissolved the triglycerides, composed of dissolved triglycerides. So these are the radially arranged crystals due to formed because of dissolving of triglycerides due to cold. Later on, the fat gets necrosis surrounded by chronic inflammatory infiltrate with multiple foreign body type giant cells. Clinical features. Infant who develop subcutaneous fat necrosis are full-term. They are associated with neonatal asphyxia and trauma. It is generally felt that some form of neonatal distress reduces the blood supply to the neonatal fatty tissue, or in other words, diverting the blood flow from fatty tissue to vital organs, resulting in necrosis of the fatty tissue. So the lesions appear as crusted ulcerated nodules on both cheek. Nodular thickening of subcutaneous tissue is detected from 2nd to 21st days of life. These lesions are painful. Nodules tend to be symmetrically distributed with special predilection to buttock, thigh, shoulder, back, cheek, and arms. So areas of thick panniculus. Lesions are single or multiple, round or oval, pea-sized to many centimeter in diameter. They may be discrete or fused to form large plaques. They may be rubbery or hard to touch and are not attached to the deeper structure. The overlying skin is red or bluish red. Nodules continue to develop for a week or more. In most cases, child health is not substantially impaired, and in few months, the nodules disappear. Sometimes calcium deposition occur in the nodules, and the lesions take rather longer to resolve. There may be slight atrophy, or the nodules may ulcerate and discharge their fatty content and leave scars. The condition has occasionally been fatal, particularly when the visceral fat is involved and where there is complicating hypercalcemia. Differential diagnosis. The condition is frequently confused with scleroderma neonatorum. Occasionally, two conditions may occur simultaneously. The complications and comorbidities. Subcutaneous fat necrosis of newborn is associated with hypercalcemia, especially in infants with extensive disease. It may be due to increased calcium absorption due to extrarenal production of 1,25-dihydroxy vitamin D. The nephrocalcinosis is common. Transient thrombocytopenia develops during period of initial development of the lesions, possibly due to sequestration of the platelets. Plasma lipid abnormality have been reported. The disease course and prognosis. The skin condition resolves over several weeks, although the hypercalcemia can persist for a few months. Skin biopsy is required to confirm the diagnosis, and serum calcium need to be monitored for 3 months. Management. No treatment is generally required as condition is spontaneously resolving in several weeks. Analgesia may be required. Sometimes hypercalcemia should be treated aggressively to prevent the soft tissue calcification. And this treatment includes diuretics, dietary restriction of calcium and vitamin D, and sometimes oral corticosteroid because these corticosteroids interfere with metabolism of vitamin D. In resistant cases, biphosphonates can be used. Furosemide is used to achieve increased calcium secretion and inhibiting calcium reabsorption. So the last condition to be discussed is scleroderma neonatorum. It is a rare panniculitis with invariably high mortality. The affected infants are gravely ill, preterm, and disease is involved in first week of life. It manifests as diffuse hardening of the skin and subcutaneous adipose tissue to such an extent that it hinders feeding, respiration, and culminates to the death. Equal sex incidence, and there is always an underlying severe illness. Pathophysiology, prematurity and small for date is the main predisposing factor. This disorder does not occur in healthy infants and is associated with wide variety of severe illnesses, particularly serious infections, congenital heart diseases, and developmental defects. A portion of these infants are hypothermic and is described as a complication of neonatal cold injury. Nevertheless, cold does not appear to be the most important etiological factor in most of these cases. It is suggested that scleroderma might reflect defective lipolysis within the adipose tissue, which would result in failure of fat mobilization and impaired capacity to maintain the body temperature. The ratio of saturated to unsaturated fatty acid, is relatively high in all neonates. That leads to a high melting point, and it is possible that induration of subcutaneous fat reflects its solidification due to fall in the temperature of adipose tissue due to peripheral circulatory collapse. Pathology. Most cases of subcutaneous fat layer appear to be thickened due to increased size of individual lipocytes, increased width of intersecting bands of connective tissue, all due to edema. There is little evidence of fat necrosis and slight indication of inflammation. The most characteristic histopathological feature is the presence of radially arranged needle-shaped clefts within the adipocytes due to solidified triglycerides and surrounding multinucleated giant cells. Clinical features. Scleroderma neonatorum was once called as the skin-bound disease. Its previous name was the skin-bound disease. In 1817, Albert introduced the term scleroderma, which is derived from the Greek word meaning hard. Considered to be a non-specific sign of severe illness with mortality ranging from 82 to 98%. The affected infants are gravely ill at the time of scleroderma. Woody induration of skin starts at the buttock, then goes to thigh, calves, and rapidly and symmetrically involve the whole surface, and with the exception of palm soles and genitalia. The skin is bound to the adjacent subcutaneous tissue, including the muscle and bone, and therefore it cannot be pitted by pressure or pinched into the fold. The skin is hard and cold to touch, yellowish white in color with purplish mottling. There is immobility of extremities and face show mask-like expression. This is the woody hard induration of the skin of the back. The main diagnostic confusion is subcutaneous fat necrosis. And the distinguishing features are many. It is also has to be differentiated from Turner syndrome, which is present in female as firm non-pitting lymphedema of dorsa of hand and feet with low birth weight and loose folds of skin around the neck. Presence of edema at birth is very slowly progression in a healthy neonate distinguishes primary lymphedema from scleroderma. Prognosis is poor and largely determined by nature of underlying disease. In spite of advances in treatment, many of the predisposing disorders, particularly sepsis, sets in and mortality remains in excess of 50%. Infants who survive, the appearance of skin return to normal without long-term complications such as calcification, which was common in subcutaneous fat necrosis. Complications, as mentioned, is respiratory insufficiency due to restricted movement of chest wall. Skin biopsy is most useful test. Management is, first of all, treat the underlying medical condition. Secondly, systemic corticosteroids, probably not effective, but there is evidence that repeated exchange transfusions and intravenous immunoglobulin is helpful in some cases. So this table distinguishes neonatal cold injury, scleroderma neonatorum, and subcutaneous fat necrosis. First of all, the patient. Both neonatal cold injury and subcutaneous fat necrosis, the infant is a full-term healthy neonate. But in neonatal cold injury, sometimes there are small for dates, babies, and particularly born at home. But in scleroderma neonatorum, It is in the severely ill neonates, which are preterm or small for dates. Onset is in the first week in neonatal cold injury and sclera neonatorum, but it is later around about 1 to 6 weeks in subcutaneous fat necrosis. Sites are mainly extremities in neonatal cold injury, trunk and spreading to extremities in sclera neonatorum, trunk, buttocks, thighs, and arm and face in subcutaneous fat necrosis. There is pitting edema in neonatal cold injury with redness and cyanosis, while non-pitting edema or woody hard induration and immobility is seen in sclera neonatorum. Subcutaneous fat necrosis is not diffuse, but rather it is reddish-violet subcutaneous nodules. Histology: neonatal cold injury is thin panniculus. Sclera neonatorum is subtle, thick, connective tissue trabecally with needle-like clefts. Subcutaneous fat necrosis, again fat necrosis with needle-like clefts. Mortality is highest in sclera neonatorum, more than 50%, around 25% in neonatal cold injury, while absolutely no risk to life in subcutaneous fat necrosis. Thank you all for today's listening. Hope to see you next time with another edition of my lectures. Goodbye and have a very good day.